Good afternoon, everyone. Thank you for your energy and patience at the end of the day. I'm going to start off the session by talking about tuberculosis for a few minutes, and then Dr. Altice will take it away and talk about HIV. We're here today to talk about opportunities for implementation science. Quick disclosures. Yale says I'm supposed to tell you. My spouse had a previous life in pharma. Not relevant, but moving on. Okay, so why is tuberculosis important? Why is it important that we talk about this? So tuberculosis. Hopefully this is review, but as a reminder, tuberculosis is, after COVID, the leading cause of infectious death in the world. Huge problem. You may be surprised to know, many people are, that it's been years now that deaths from tuberculosis have surpassed that of HIV. What do you know more about, HIV or tuberculosis? What gets more attention? HIV, yes. A lot of people saying that. It's true. And you'll see that being multiple times. HIV gets a considerable amount of attention, as it should, as being a public health epidemic. TB tends to be more neglected, but is a massive global epidemic as well. So for review, tuberculosis is caused by a bacteria, transmitted respiratory route, clinically manifests primarily as pulmonary disease, but approximately 20% globally is extrapulmonary, and that manifests in a wide variety of ways: spine, joints, genitourinary, meningeal. People who are immunocompromised or have weakened immune systems are at the greatest risk. People who have immunodeficiency, HIV, diabetes, end-stage renal disease, other risk factors like alcohol, etc., smoking as well. People who are older and have immunosenescence, people with rheumatologic conditions, or other conditions requiring immunosuppressive medications. We've made a tremendous amount of progress with tuberculosis. We have wonderful diagnostic tools, AFB, culture, more recently rapid molecular tests, GeneXpert in particular. We have efficacious treatment for drug-susceptible and drug-resistant tuberculosis. And we made a tremendous amount of progress in shortening the regimens so that they're more tolerable for patients and more patient-centered. We have, for prevention, we have a tremendous amount of progress in shortening those regimens. Again, more patient-centered, better treatment completion rates. So why is it, since we have effective diagnostics, treatments, and prevention, that we still have 10 million cases globally every year with increasing incidence, and unfortunately now, for the first time in more than a decade, increasing mortality? We have the tools. So why are we still seeing this as a public health problem and a clinical problem? Largely because of the lack of implementation. Right. So that's why we're here today. The effect of COVID has also contributed to this. So these are slides from the WHO about the state of global tuberculosis. So the COVID pandemic, just like it's hit every sector of health, it's also hit tuberculosis and been very damaging. So the total number of people who have been detected with tuberculosis overall has dropped tremendously, and we haven't fully recovered yet. Some estimates are saying that we've regressed 12 to 15 years in terms of global TB control. So you can see this is tricky. There. So we've only made a partial recovery. There's still an estimated millions that we are not diagnosing. They're still there. They're not coming to clinical attention, or they're coming to clinical attention and we are not detecting them. Overall, there's been a decline in TB incidence, almost 4%. Again, we know that people suddenly stopped getting tuberculosis. They're still there. So these are biases in detection. The latest WHO NTB strategy, the goals were to decrease by 10%. We've not anywhere near that at this point. And in terms of mortality, as I said, TB is second only to COVID. You can see that 1.4 million died of tuberculosis in 2019, and that has been creeping up, 1.5 million in 2020, up to 1.6 million now. So this is not the direction that we want to be going in. So where are we in Malaysia? According to the information that I was able to find from the National Ministry of Health, the case notifications have been largely stable, according to the last reporting numbers, 79 per 100,000 to 72 per 100,000. And mortality has actually increased tremendously, 5.5 to 7.1 per 100,000. So this is certainly a cause for concern, and this is perhaps partially related to COVID in 2020, just like what we're seeing in the rest of the world. How much do prisons contribute to this? And say, globally, prisons are a hotspot for TB transmission and contribute tremendously to national TB rates. There's structural issues and then individual issues to consider. Structurally, certainly the setting, the venue of prisons, there's crowding, there's poor ventilation, there's policies that keep people who are particularly vulnerable to tuberculosis with multiple coalescing risk factors in that particular setting. So in particular, as an example, people who inject drugs, who often have multiple comorbidities that put them at increased risk, face punitive policies for drug use, and are repeatedly incarcerated. On an individual level, as I mentioned, people have multiple comorbidities. So HIV, malnutrition, OUD, hepatitis C, multiple factors that contribute. So why should we be paying attention to the prison setting? How much does TB in the prisons contribute? A tremendous amount. But what should we do about the prisons? Are we treat them the same way that we do people who are in the general community, people who are walking into UMNC? So the bottom line, we had last year, for those of you who were here, we had a whole session about human rights and how people in prison may not be able to access those rights, but basically that every person, including people who are in prison, have human rights that justify their access to health care. If that's not reason enough to focus on prison health care and make sure that we have equitable care in all settings, and that every single person has access to equitable health care, let me just talk about this very elegant study that demonstrates a little bit more about the contribution of prison tuberculosis to general community tuberculosis. So this was a study done by colleagues in Brazil and in the US that integrated genomic, epidemiologic, and incarceration data in Brazil, which has a high tuberculosis burden. And they were able to genome sequence more than 1,100 isolates and look at the genomic clusters that resulted. And nearly 71% of those clusters included people with incarceration history and those who had no incarceration history. 71%. So there's a tremendous amount of mixing. If the epidemics of tuberculosis in the internal community and the prisons were completely separate, they would be very clumped. You would have genomic clusters that were common in the prisons and genomic clusters that would be common in the community. But we're seeing a lot of mixing there. And among people who have no incarceration history, 50% were in clusters with people who did have an incarceration history. I think overall, at a minimum, they were able to estimate 15 to 20% of the tuberculosis that they did the genomic analysis on were a result of TB that had occurred in the prison system. And that was a minimum estimate. So a tremendous amount of the tuberculosis epidemic is perpetuated potentially by what's happening in prisons, and so deserves our attention. So where are we? This is a study that was just published this month in The Lancet, looking at the contribution of tuberculosis globally in prison settings. And you can see Brazil is at the top of the list in terms of the amount of tuberculosis in their prison system, followed by Russia, China, Philippines, Thailand, India, South Africa. And about halfway down the list, or third way down the list, is Malaysia. It's 13th on the list. So this is a substantial problem here as well. So how can implementation science help us to improve TB care in the prison system? So we're going to use the framework of the cascade, the TB cascade. And I'm not sure if anyone's familiar with the cascade approach. I'm seeing some head nods. It's commonly used in HIV. It's been adopted by the TB world as well. So we start off by the total number of people who have active TB disease. And we're talking completely here about active TB, not latent. Okay. And then we have the proportion of people that were subsequently accessing diagnostic evaluation. And then how many people were diagnosed with tuberculosis actually after result of that evaluation. As a result of after being diagnosed, how many were actually registered and started treatment. Of those that started treatment, how many completed treatment or experienced treatment success. And then how many had recurrence-free survival. So using that framework, we want to think about how we can keep these bars straight across so that there's no loss at any point in the cascade. Everybody that has tuberculosis gets diagnosed, everybody that gets diagnosed gets put on treatment, and everybody that gets put on treatment completes treatment and is cured. But we know in reality that we have loss at every single step of this cascade. And that cascade is particularly more pronounced in terms of loss at every step in prison systems. So in terms of that first step, trying to detect everybody that has tuberculosis, only recently, only in 2021, did the WHO finally incorporate prisons into priorities for screening. So it's still a relatively new recommendation. But with the accumulation of data from all over the world demonstrating the burden of tuberculosis in prison settings, and a lot of advocacy work, including from Prof. Althisen, Prof. Adiba, and others, they've now finally incorporated this into formal recommendations. So this is the actual wording from the systematic screening for TB disease should be conducted in prisons and penitentiary institutions. Strong recommendation, very low certainty of evidence. You'll note there are no guidelines here though, no specificity at all on how best to do this. What strategies to use, what are the best practices, and so we are left now with a paucity of evidence on how best to conduct this. So what are the potential implementation science questions that we can take from that. What are the optimal strategies for screening in prison settings? What are the best tools to use? How do we use, what's the role for chest x-ray compared to other tests? There's a lot of interest in CRP lately, and some very intriguing data on its use in screening protocols. How can we use CRP aside from other point-of-care tests? What are the best combinations of tests to use for people in prison, given that they are particularly high risk? Should screening be conducted on everybody entering prison, or only those with certain risk factors? What's the optimal frequency of screening? We have no data to guide us on any of these. So a whole area for us to investigate and contribute to how to improve TB care in prisons. So let's start with screening, the first step, the first gap. And for all of these, we want to understand the context. We want to understand more about what's happening in the prison system. And I'm showing you two different implementation science frameworks. On the left is the EPIS framework, which Prof. Rick introduced me to. And on the right is the CFER framework, which Prof. Luke had introduced me to. Regardless, and I highlight them both because I know it's always a question people are asking, which framework do I use? But regardless, you can see or maybe it's a little bit hard to see in this, it's getting smaller, but the context is something you want to evaluate regardless. And in particular in EPIS and in CFER, you're looking at the inner context and the outer context. What's happening at a patient level, potentially, what's happening on an administrative level is one way to interpret that. Another potential way of thinking about things is using SET, or Screening Evaluation Treatment. You might have heard Prof. Rick mentioning this yesterday. How do we think about these different stages of this approach? And where are all these things happening? Another way to think about it is just process mapping. Where are all these things happening now? So, there's some formatting issues there. The screening is often done once people have arrived at the prison, either upon entry or at some point after prison entry. But if someone has symptoms, they have to be sent out of the side of the prison. There's no diagnostic capacity inside. They have to go to their local clinic. And that takes time to organize at the prison level, takes staffing and guards and transportation, all of which were particularly challenging during COVID. And so then you experience delays. And so someone potentially with active TB disease and who is incommunicable remains in the prison and potentially transmitting to others around. So this is a challenge. And then even once people may be taken to the clinic and evaluated and hopefully diagnosed, treatment, once the tests come back, if their sputum is collected for AFB and culture, the results come back in the next week or two, again, all that while people are waiting. Then they have to go back to the clinic outside the prison to initiate treatment, and back to the clinic outside the prison to have their treatment monitored and treatment completion assessed. So all of that's happening outside of the prison. And the back and forth not only potentially provides risk to community members, but is an administrative and logistical burden. Context, again, is critical. So what's happening that makes this cascade even more difficult? So from a government perspective, there's a lot of challenge in procuring and establishing rapid point-of-care diagnostics, rapid molecular diagnostics. There's a pressure to adhere to national guidelines, which up until very recently did not include rapid molecular diagnostics. We relied solely on AFB and culture. which, as we all know, takes up to 6 weeks to return. And also, there's a division of work, because the prison healthcare falls under the prison system, not under MLA, not under the Ministry of Health. And so who's responsible for which parts of the healthcare in the prison setting is a very challenging issue. On the prison side, again, they may not have the resources to implement rapid diagnostics, or the staffing. As I mentioned, staffing and the time and the transportation remains a logistical barrier to people getting timely diagnostic evaluations and treatment initiation. We recently completed a quantitative survey amongst the prison staff, almost more than 245 people. And there's consensus that TB is a very serious problem, that there's concerns about transmission, including to the prison staff. So this is helping us to understand what we need to do next. So what were the goals of the HARPON study? Some of you may be familiar, but just for review. And I'll say that the HARPON study was not designed initially as an implementation study. So we're picking up a few pieces to highlight here for the purposes of this discussion. But the overall goal here was to complete a comprehensive diagnostic study using multiple different methods so we can determine what is the optimal screening procedure for prison settings. And looking also at yield of screening, determining prevalence. So for this is all based at Cadron Prison. On prison entry, we've developed a protocol for screening people with opioid use disorder as an example of focusing on a particularly high-risk patient population. About a year ago, we expanded to all people entering prisons as being eligible. We did an individual level assessment, including a whole slurry of screening tests, including symptomatology, blood work, rapid HIV testing, skin testing, sputum evaluation, including for GeneXpert that we were able to perform on site. And being culture, obviously went out to an outside lab, and we were able to arrange for chest x-ray to come to the prison and be done right outside the prison door. So these are initial results through the end of 2022. So just focusing on overall 1,700 people were screened for study eligibility, to be clear about study processes versus the actual clinical assessment. 1,268 who were eligible, 1,254 consented, 1,151 who completed this, who went through all the screening procedures, and 87 who were diagnosed with active tuberculosis. So that's a percent of 7.6% overall, which is a tremendous amount of tuberculosis in prison settings. And the number needed to screen to find one active TB case, 13. Almost 1 every 10, or 1 every 15. Approximately 11% were concurrent HIV. Of course. So this, I was focusing here on the active tuberculosis, and I haven't included numbers for the latent TB, but there was upwards of 60% with latent TB, excuse me. And those are people who went through this whole screening protocol and that were deemed not to have active TB on the basis of all the testing, including sputum evaluation, but had a positive skin test as well, and an x-ray that would not indicate active disease. So we have, oh, yes?
I noticed that there were 103 of those who consented did not complete the screening. Were there any particular factors that they didn't complete the screening?
There was a variety of factors that affected laws throughout that. I think a lot of the people who may have consented then either decided that they didn't want to participate because sometimes they were worried about being prevented from being transferred to another prison if they started entering the study, which wasn't necessarily true, or they were transferred independently before the study could start. There's multiple factors that contributed. Or people changed their minds once they consented. Things like that. The next step, we need to go through the gaps here, in terms of diagnosis. So how do we want to diagnose people in the prison setting? We talked about the challenges along the cascade. So as I mentioned earlier, we incorporated GeneXpert, which, for those of you that may not be familiar, is this fancy-looking machine. It's a PCR-based assay that, with a processed sputum, you need at least 2 mLs of sputum. It goes in with a single cartridge. And this is a machine, I think, that holds 4 cartridges, but you have machines that can do up to 64 cartridges at a time. Actually, no, I think 128 now. But you have a result within 2 hours. And there's several versions into this from the original technology that came out in 2011 that have increased the sensitivity each time. So we have terrific technology that can diagnose people within a couple of hours instead of leaving the prison and submitting an AFB in culture that'll come back over weeks. This is what I have here, and this is out of the flow 51, 87 cases, 7.6%. And this is the breakdown of the diagnoses, how we were able to diagnose those 87 cases. You can see the greatest contribution from GeneXpert there. So on the left, you have the proportion of TB cases where the AFB and culture were positive and the GeneXpert was negative. So no GeneXpert involved in this, no contribution there. And you have identified 7 cases. And on the right, you have those that were AFB and culture negative and GeneXpert positive. And that was 36, 5 times the number of cases. So which technology would you rather have? Is anybody voting for the AFB and culture? Okay, good.
How do you explain that they were expert negative? Is that unknown?
Yeah, it's a good question. Prof. Sten is asking, how do you explain cases that were GeneXpert negative? And there is always sampling issues.
Yeah.
When you're collecting multiple specimens or multiple sputums from one person, you may not always have the luxury of waiting multiple days to collect the optimal specimen. These are not necessarily early morning specimens as well. That's the ideal time to collect a specimen from someone who we worry about tuberculosis in. Because remember, you have respiratory specimens that are in theory pooled overnight. And so the first early morning specimen is the best one to use. But again, if you're trying to collect multiple specimens from somebody, and you're sending some off for cultures, some off for GeneXpert, you're not always going to get your ideal sampling. So on this side, if we have no expert involved in our screening regimens, the number needed to screen, which is an important metric for any screening test, right? The number needed to screen to identify one case of active tuberculosis is 23. And on the right, when you have expert in your algorithm, the number needed to screen to find one active case of tuberculosis is 13. So if you're in charge of the TB program, what would you rather have in your diagnostic armamentarium? What do you want to rely on more? Okay. So having a rapid point of care tool that's going to allow you to get people on treatment as quickly as possible and limit transmission in a high-risk environment is critical. Okay. The next gap, once you diagnose somebody, is to getting them on treatment. And again, we talked about the mapping. People have to leave the prison, get to a clinic, and start treatment, and then have to come back to the clinic for monitoring, right? So amongst the cases that we've identified, 20% were not initiated on treatment for a variety of reasons. One, before the policy changed, before GeneXpert was considered a diagnostic tool to be used, and that results from the GeneXpert were going to be accepted as a criteria for initiating treatment. There was some loss there. During COVID, there was a decarceration effort, and so people were released, and potentially some of those people had tuberculosis and went untreated. And then again, as I mentioned, some of the logistics in terms of getting people to the clinic, especially during COVID lockdown, and sometimes people were lost. The other thing is time to treatment. Even with the rapid point of care, 2-hour turnaround diagnostic test, people were waiting for a great deal of time before starting TB treatment. And this is not conducive to stopping spread within a closed system, such as the prisons. So how can we address those? What are the opportunities here? Thankfully, with collaboration with the Ministry of Health on this project, they've decided to change the prisons to a PR1 status that will allow the prisons to initiate treatment inside the prison, which is a tremendous advance. Very exciting development that will allow people to be initiated in treatment much more rapidly, without delays, which will be good for not only the prison population, but also the staff of the prisons. And we'll definitely take this a step forward in terms of reducing TB incidence and overall control. As I understand, the PR1 status also extends to ART as well for people with HIV, which is tremendously exciting. We'll definitely move the needle forward on incidents. Will this particular effort be enough to ensure everyone is initiated on treatment? That people will start TB treatment in a timely fashion. So these are questions. We're not sure. Again, opportunities for assessing the implementation. And how best can we do that? Who can think of a design that would work? From Professor Ben's lecture yesterday. No takers. There may be some quasi-experimental designs, perhaps a time interrupted series that may be helpful here to assess the policy shift, right? Change in practice. So I'm not sure if this is the only implementation effort that's going to make all the difference. I think there's other things that we need to look at as well. We want to ensure that there's going to be a rapid diagnostics as well that would allow us to make the diagnosis quickly. And we hope that that's going to be a future investment. So there are multiple opportunities. We've only highlighted the first few gaps for using implementation science to bring evidence-based interventions to improve overall TB care. There's many more other implementation science questions that we can ask specific to tuberculosis and infectious and communicable diseases in general in the prison system. And challenging environment for a lot of the reasons that we've talked about today. But I encourage you to think about where we can contribute. Any questions from anybody? I'd like to acknowledge, just quickly like to acknowledge the HeartPod2 team, I think some of whom are in the room today. An amazing team that I've had the privilege of working with, including Sanama, who's sitting up here at the front table, Cherry in University of Malaysia, the Prisons Department, who has been a terrific partner, as well as the Ministry of Health, Prof. Adiba, who I don't think is here at this moment, and certainly Prof. Rick for this opportunity. Any questions from anybody? Professor?
In some ways, your the transformation of the status of the hospital is almost equal to the impact of your study itself. I did a TB survey in a prison in Pakistan about 10 years ago with a student, and we found very high rates, and it was very disturbing. But we couldn't get any traction on the policy side. So it's an article sitting in literature that made no impact. It doesn't qualify as implementation science. It only qualifies as an epidemiology survey. And you are actually making a policy impact to make it easier to treat people in the hospital. Would you care to comment how you accomplished this? What were the actions of your research team and Prof. Adiba, and what made a difference that the government changed the status of prisons to make them clinic friendly?
No, that's a very good question. I think there's part of it is just the development of the partnership and the level of rapport and trust that's been built over time. That's a huge contributor. This has been a recent development. And Assad was sitting in the room with Dr. Saeed having this conversation with the Ministry of Health. And if you want to say anything about that conversation, Assad.
Yeah, I think a lot of the, thank you, Dr. Sheila. I think a lot of it has to do with the fact that we presented the delayed treatment initiation for active TB, because the TB mortality rate, because it had gone so high, it was quite a concern for our counterparts at the Ministry of Health. And when we shared the data that it was about 41 to 42 days delay, it got them really worried and really upset because they took a lot of pride in that program. So I think when we showed that there was a gap in the program, they really responded quickly to that.
I think similarly, I think when we talked a year or two ago with them about the impact and the contribution of GeneXpert, there was a lot more excitement about the new technology and the impact it could have on improving TB care. So that kind of allowed us to change how they were responding to some of the diagnostic testing that we were doing that was outside of the traditional national guidelines at that time. So the communication and the rapport between the research staff at Cherry at University of Maryland and the Ministry of Health, I think, is key in that partnership in facilitating change. Any question?
Thanks. I'm Suresh. So I would like to ask on TB's effort, TB's control effort as in prison. As in, we get a lot of patients who are seen at prison, from prison in hospitals, where they get released as they are remand cases, right? So when they reach prison and then they go out, instead of going back to they get released rather. So there's a chance that we might miss those people even though they are started as treatment in the PR1 in the hospital, for example. So that's one of the major issues where we have with prisons. I saw the PR1 as in prisons becoming PR1 fix that. But to begin with, prisons and hospital, as you mentioned earlier, we don't have a working relationship, as in a formal relationship where they share data, and because it's not designed for that, right? Is there any efforts? Number one, is there any efforts in that direction to make to cater specifically to that prison population? And number two, since we are from hospital side, we get a lot of our main concern is kadar putus rawatan, as in defaulters rate. So The default is usually because there's a lot of issues, as in they don't have transport to reach the center, or they don't have how do I say, it's the side effect, it's the lack of counseling. This is a lot of social issues. They might have other comorbidities where the drug is interacting with it, or this kind of things. So they get we typically see patients where they get started with TB treatments, and then over the course of treatment they just lost. So is there any specific interventions planned in that? I mean, based on it. So that's my question. Thanks.
Both very good questions. In terms of the defaulter, and I can't speak for the Ministry of Health, obviously. I'm not sure if anybody's here from Ministry of Health. I was speaking with someone at lunchtime. They're very concerned about the loss to follow-up, which I think is about 10% at this point, if I understood her correctly earlier. They're very concerned about that. I think it's a little bit unclear what's leading to the loss to follow-up. What are the reasons? Is it that people have concurrent medical conditions or comorbidities that are interfering with TB follow-up and care and treatment completion? Perhaps substance use disorders or other mental health disorders or other medical conditions that require acute treatment and perhaps prevent them from coming back for TB follow-up. Could we do better at integrating care across health conditions? Is it that people do not have money, they're coming out of prison and they're poor, still adjusting to life in the community, getting settled, have other competing priorities, they're not able to financially sustain getting to the TB clinic for follow-up, like their medications. I think we need to have a better understanding of what the reasons are that contribute to loss of follow-up. Do they have concurrent HIV? Are they taking their ART? Are they prioritizing their ART over their tuberculosis medications, for example, because they have to go to 2 different clinics in different parts of the city to get both of those? I think we need to understand more what are the reasons or what are the obstacles that patients are facing. I think there are plans to evaluate what are the reasons and to look at the data that already exists at the national level versus what more prospective evaluation we need to do. So they're looking into what data systems that they already have. And I'm sorry, your first question again was?
Whether there's any plans to integrate the prison and the health sector as into to facilitate this whole program as a TB program.
Again, I don't know that I can speak for the Ministry of Health and the Prisons Department. It would be wonderful if there was more integrated care. On a higher level, I'm not sure exactly what the plans would be to do that. I think people across all of these sectors are talking to each other though, and that's the first step, right? Recognizing that there's a need for integrated systems, and that the people who are traversing all of these different sectors are one and the same, and so we all need to work together to address their care. I hope so.
Any other questions before we move on to Dr. Altice's presentation?
Okay, now it's time for Dr. Altice to take it away.
All right. Welcome to the stage.
Right, there's going to be some of the same themes that we're going to go over. I'm going to start out by just sort of setting the stage about what the landscape looks like. How many people have been inside of a prison or a jail before? Okay, so we've got at least probably 2/3 who haven't done time, maybe a different kind of time. And so I'm going to really sort of paint some of the stage and sort of really sort of build upon the presentation yesterday in writing a grant. So part of what I want to do is I want to really talk about why, thank you, this is a significant problem, all right? So whatever you're doing in implementation science has got to be significant. We try to identify the gaps and we try to look for the opportunities. First of all, I just want to start out because part of this particular program also involves health and human rights. I want to make sure that we're using some of the right language, people-centered language when we're talking about what oftentimes people refer to as prisoners. And so I think the terminology that I'd like to hear people talking about, and this is starting to emerge in the international community, is, let's say, people deprived of liberty. That's very broad. You could say people who are experiencing incarceration, and I have to say I just wrote an article using PDL, and the reviewer says, what the heck is that? Can't we just call it prisoners? And I said, no. And then people in prisons or jails using people-centered language. And then I think the other sort of part is people who are transitioning from incarceration. And we're going to get at some of the implementation, but I really wanted to start out with making sure that we're all using some of the right language around some of this. So really getting into why it's important, it's big. It's 10.2 million people are in a closed setting on any one day. You say, okay, 10 million, not that big of a deal. But that really doesn't really describe what the problem is. These are places that has incredibly high turnover, such that there's somewhere between 40 and 70 million people who are in a closed setting over the course of a year. So it's actually much, much more robust than just the 10 million people. And part of the issue with that is you've got some of these places that really differ in terms of what your implementation opportunities are. So if you've got someone who's in pretrial detention, another name for that might be jails, the interventions and the way that you implement is going to be a lot faster. You've got a person who might be spending a day or 2 or 3, very, very short periods of times. You have quick opportunities to do something quick, and that's it. You don't have a chance to go and interview, 15 things to do. So the types of things that you might do in a jail may be different in a in a prison where you have actually access to really evaluate and do a little bit more sort of screening, evaluation, and treatment. I know in Asia, including in Malaysia, Vietnam, and a few other countries, there are compulsory drug detention centers that are present. And then there are also, in terms of our criminal justice setting, and they're not closed systems, but they're places to also potentially intervene. And I'm not going to go into these, but we call them probation and parole. And these are people who are at incredibly high risk for HIV and tuberculosis and a number of other sorts of things. So I don't want to lose that in terms of the criminal justice system. And I will say parenthetically that the criminal justice system even goes beyond that. It can go all the way to the beginning, which is your sort of police interventions. And there are opportunities at police lockup. We're doing some work in Central Asia at people who get arrested just for like a few hours and maybe intervening there. There's drug courts, or there's courts in general, so there are other places to intervene. And the unfortunate thing is, despite the fact that we know that incarceration is just a failed strategy. Sten and I were talking a little bit more about where the focus in, let's say, in Scandinavia, in Norway, is completely on rehabilitation. And there was a movement in the 1970s where places were called departments of correction. Before that, they were penitentiaries, places where people did penitence. And then they said, okay, let's try to do rehabilitation. And then I think that many of the places around the world took on a more hostile approach to this, and they really come back to being, sort of penitentiaries where people are sort of locked away and really not really seen. And then the incarceration rate differs based upon the criminalization, mostly of drug use in many places around the world, with the average globally being 144 per 100,000. I want you to remember that number because I'm going to show you some numbers from around the globe. So let's just take a look at what it looks like. Well, guess what? Our home country is the worst offender in the world. It's literally many times, it's like almost 7 times greater than it is in the rest of the world. And also in, let's say, the Caribbean, 376, South America, 202. Let's move over to Eastern Europe, 475. So it's really sort of getting up in there. Central Asia, 225. Western Europe, only 98, well below the average. I mean, I shouldn't say only 98, but it's much lower than the global average. Areas of Western Africa, being 46, Southern Africa being 205, pretty significant. And then some areas in Asia, India being low at 62, China being at 160. So we've got these variations. Malaysia is actually right about on the average globally in terms of the rate of incarceration, and then Australia at 151. So this is another way of looking at where the deepest levels of concentration are. So we've got a handful of places. Sheila was talking about Brazil in South America. You've got the US, you've got Russia, and a number of these other sort of places here as well. Now, what ends up happening is that incarceration is really a strategy where, based upon criminalization, people get locked up. So when you have fairly high rates of criminalization of drug use, that is really going to be a driver of all of the things that are associated with that. HIV, hepatitis C, tuberculosis, all of these other sorts of things. Alcohol, independently, which is in most places in the world is a legal drug, is also a major rate due to the secondary downstream consequences of that. And then one of the things that's really another driver of this is not only is drug use related to a single incarceration, but it's also related to people being reincarcerated. So these people have repetitive episodes of interacting with the criminal justice system. And so, that's really what we're looking at. This is a framework that Adib and I put together for a Lancet article thinking about what happens, at least in terms of the whole realm. And if you think about this, I want you to sort of think about where there are some, this is in the absence of doing anything. By the way, all my slides, you can have them, they're good. This is published in Lancet, so you can get it from there as well. But we have people within the community who are likely to be incarcerated, people who are homeless, people who have substance use disorders, the trans-institutionalization of people with underlying psychiatric disorders, people with substance use disorders. So what happens is people with lots of disease get concentrated in these places. And so on one hand, you can sort of think of this as an excellent place to identify people who have been failed by our communities. Our communities have failed to engage them in effective ways. And not that I think that incarceration is the right answer, but when societies have decided that incarceration is their strategy, I think we do have an opportunity to be able to make a difference, because good prison health is good public health, all right? So I want to really make sure that we get that point out. Then what ends up happening is that with concentration, in the case of tuberculosis that Sheila pointed out, it becomes an amplification. You put people with a disease in a crowded situation, you have amplification of disease. You put people with HIV who have limited access to sterile injection equipment, and they inject and they transmit HIV. So we actually have amplification of many diseases within these settings. Then what happens is we have healthcare systems within prisons that are undersourced with regard to resources, medications, and people power. And what happens is that people deteriorate from disease because the setting isn't there. And then the really awful part of this is that people are taken out of their social networks and the people who support them in communities. And they then are taken away from that. When they reconnect in society, their networks have changed. So their risk goes up because they're coming back into environments that are incredibly vulnerable, and they don't know the landscape in the same sort of way that they did before. So then it results in sort of a dissemination of disease, because what we have found in our studies is that people who engage or who leave prison, who are at risk through injection drug use, their risk of HIV is 4 times greater than people who inject drugs who've never been incarcerated. So, all right, so this is really an important piece of this. This transition from incarceration is really dangerous. It's dangerous from an HIV risk perspective, but it's also dangerous because people relapse to drugs and they overdose and they go to heaven, all right? So really, incarceration should really be seen as a dangerous place to be. And then once people get out, and whether there's a disruption of social networks after that, there is dissemination further of disease, and then of course that's associated with post-release morbidity and mortality. So the prison context is one, first of all, that is oftentimes outside of the public purview. So the standards of care that we have set in our communities oftentimes do not apply to what happens in prisons, despite the Nelson Mandela rules, which talks about an equivalence of care that should be delivered. But because there is not the scrutiny, prisons departments, their job is to sort of keep the community safe, and so they don't really want people looking in there. So there's no sense of real governance that happens there. They're often poorly resourced, they have understaffing. When you want to sort of get something done in a prison, you don't ask the doctors to do things, you ask the nurses, because that's who's in the prison. The medical assistants, these are the folks who do things. So when you're thinking about unusual, implementation opportunities, we think about task shifting. One of the things that we'll probably have some conversation about is when you don't have a doctor who's specializing in X, Y, or Z available, how do you get that doctor in? But how many doctors really want to go to prison? I only saw 1/3 of the people raise their hands. People don't really want, I go into prison, and they let me out because of good behavior, I suppose. But, I go into prisons, I see patients here, but most people don't. So how do you get a really good doctor into a prison? I think you teleport them through telemedicine. This becomes an implementation opportunity to be able to do that, or as Jen Edelman spoke about. The other model is that you enhance the service delivery by educating people. Things such as teleeducation like Project Echo. So these become, once again, implementation opportunities to provide the resources that are available outside into these insights. And it is especially true if you're sort of taking a look at where prisons are located. People, if you're in Kuala Lumpur, do you want a prison in your backyard? The answer is absolutely no. You want them in the kampung. You want them way the heck out of Dodge. And the doctors aren't going to be there. So how do we think about implementation opportunities that overcome some of these geographic disparities? In addition to human resources, they may not have the medical supplies. The first gene expert, as Dr. Shenoy brought it up, was the one that we provided to the prison. It wasn't really available in any other sort of way here. There's disparities in supervision. How is healthcare delivered in these prisons? There's a big debate out there. There are people on one camp who say that it should be under the Department of Correction or the Prisons Department because the prisons know how to keep things secure. Perfectly good argument. The other one says, we don't really want the guards to be sort of in charge of the healthcare. We want the Ministry of Health to do that because that is their job. All right? Now, there's always a conflict between Ministries of Health and Departments of Correction or prison departments because they have two different missions. The mission of people who deliver healthcare is to bring people to them so that they can see them and give them healthcare. Well, the guards have a completely different mission. Their mission is that I don't want them to move because every time they move from point A to point B, there are security risks. They're going to run. So let's think about these conflicts that happen. How do you overcome some of those things within a prison? Do you sort of move the care into the units? These are all implementation opportunities that I want you to think about exploiting. So rather than say that they're barriers, I always think of them, these are opportunities to be able to do something different. What is the connection with the services? With addiction treatment, in many places in the world, this is completely siloed. The medical doctors say, I don't do addiction treatment, or I don't do this, or I'm a general medical doctor, I don't do TB, I'm not a physiatrist. So these are the sorts of things, and do you have the networks and the referrals that are available? And to things like telemedicine, remember COVID was a big disruptor, and can the disruptor of what we learned from COVID now be applied in order to create an equitable access to healthcare in these settings? And then, of course, one of the things that happens almost everywhere in the world is that the people who get sent to prison to take care of patients are the people who either could not get, when I first started working in the prisons in the late 1980s, there were veterinarians who did not have medical licenses who were providing care. There were many, not that retired surgeons, are not able to do care, but they were not able to work anywhere else as a surgeon. They didn't know really any general medicine. They would ask me, well, what kind of hypertensive can I use in a patient? So I think in some places there has been some professionalism around that. Someone once told me that here in Malaysia, that you might get relegated to the prison because you weren't able to get a good spot in X, Y, or Z. I don't know if that's true, but I think that there's a general sense that they have not professionalized this in the same way that they professionalize medical care, and so there may be some differences in terms of who's able to do this work. Now, here's just some data to take a look at the concentration of substance use disorders, specifically drug use disorders in prisons. And as you can see, it's 3 times more concentrated for men and 5 times more concentrated for women. So this once again becomes an opportunity to, one, identify and screen. So you got to screen them, you got to evaluate them to see if you got the available prevention and treatment, and then you of course have to have the treatment. These are some of the things. I like to think of prisons as high-risk environments. You put people who are already engaging in high risk and you put them in a place where they're concentrated, and it becomes sort of high risk for a number of other things that is there. When you concentrate people in high levels with these sort of risk factors, it contributes to higher prevalence of these disease states. These are the rates of the prevalence of HIV in many prison systems around the world. Some of this work is from our work going across, but let's say, for instance, in Ukraine, 19.4%. Pretty darn high. Low places like Australia, 0.2%. This is a place that introduced medication-assisted therapies and harm reduction early on in the HIV epidemic. Places in sub-Saharan Africa, they look exactly like they do in the community, really sitting at fairly high rates. The other thing to think about in terms of your implementation opportunities in your HIV prevention and treatment issues is that risk continues even after incarceration. There is ongoing drug use. It's lower than it was in the community, but many people who inject drugs, when they come into prison, many of them stop. They don't use during prison, but some of them do continue. And because of boredom and being in prisons, there are people who newly initiate. And what happens is that risk environment is concentrated. Because on the outside, you might be able to get access to 10 or 20 syringes in the course of a month. Well, you might have 30 people on the same syringe, all sharing because it is a scarce resource within prisons. And so this becomes a really important place to intervene. And then oftentimes there's additional sort of hazardous risks, and that is the way that they create. If I showed you the pictures of the handmade syringes, you would just be shocked. You would say, there's no way that anyone used. But if you have a substance use disorder, you've got a little bit of heroin, you're going to find a way to use it, that's for sure. All right, let's think about sort of putting up a framework in terms of where we're going to intervene and what kinds of things we might be able to think about. So this is a framework that I developed, 30 years ago. I think that there's probably a fair amount of applicability to look at this. We have many of our folks who are coming into prison and they're engaging in higher risk. Their lives are spinning out of control with substance use disorders to just do enough to get them to land in prison. So that's the first orange bar. Once they come in, it becomes an opportunity. And it becomes an opportunity to screen for HIV and to begin to do a number of HIV prevention. One of the things that happens is that people sort of talk about this. People who inject drugs, if they come into prison, nearly all of them, 85 to 100% of them, develop viral suppression. They get access to medications. They take the medications because they've got basic needs addressed. They've got food, maybe not so good. Shelter, not the nicest accommodations in the world. And they have 3 meals a day. All of a sudden, that part of the things that they worry about in the community, where they're going to live, where they're going to eat, all of those sorts of things, get stabilized and they can focus on their health care. But it's also a place where really evidence-based prevention and treatment interventions are absolutely critical. And once people begin to get out of that cycle, they can begin to sort of think about and focus on their health care needs. Where our systems fail us is that we release people back to communities without effective transition. And I hear clinicians and other people say they don't comply with the treatment. It's our communities do not comply with helping take care of people as they leave these facilities. So we have to think about how do we structurally implement evidence-based interventions. What do we use in the community? We link people to care. We use patient navigation. We use a number of other sorts of things. But how do we apply that What I'm doing is I'm not giving you the answers, I'm proposing things for you all to think about as you begin to do this work. So here's some data just looking at the varying risks. I talked about this a little bit. If you have a person who injects drugs who has never been incarcerated, let's assign them a risk of 1. If they've ever been incarcerated, they get a risk of 2. And if they get released back to the community, the risk goes up to 4 times greater than that. All of those are factors that are associated with adverse outcomes. What I want to do from an HIV perspective is I want to use the bilateral direction of the HIV treatment to the right and the HIV prevention cascade as your opportunity. And so when a person comes into these facilities, are we running out of time? Did we just end? Are we okay? It got me down to 0 and it turned red, so I figured maybe perhaps I was supposed to stop. So basically you've got all of these people who are coming in. To jails is going to be much faster, to prisons maybe a little bit slower. And we've got these treatment cascades, and we have evidence-based practices. So we have to think about how do we get these things into patients or available to patients. So, what we want to do is we want to understand our cascade. So in Malaysia, for example, 100% of people, for the most part, get tested for HIV. They have mandatory testing in the prisons. In other places, they have routine testing. And what's really interesting is, you can have a whole conversation about the human rights approach to this, but whenever you make it just routine among care, 90+% of prisoners are willing to be tested under those circumstances. And that's because I would say that the treatment that's available, if you make it available, trumps the stigma that's associated with that, because people actually do want to live. Not 100%, so you have this opportunity. So you get them tested, and then of course, what is one of the international recommendations? Rapid start antiretroviral therapy. You could, theoretically, by just doing a symptom survey, screen them to make sure they don't have an opportunistic infection. And you could put them on antiretroviral therapy, and you could get your T cells and your viral load and all those other sorts of things. But it's probably not going to change the way you're going to do treatment. What would change your decision about treatment is whether they have tuberculosis or cryptococcal meningitis or something like that. And you could get them onto the therapy and take a look at that whole process. The same is true, you test them and they're negative. You have a whole array of primary and secondary prevention that can be used. You can have access, because we talked about within prison drug injection, the availability of syringe services program. In Canada, we are doing an implementation project using Niatex, interestingly enough, to scale up syringe services programs within the penitentiary system within Canada. PrEP, almost used in no penitentiary system anywhere in the world at this particular point. Medications for opioid use disorder, 6 cents a day, it's cheap, is one of the probably the most effective ones. And not only does it have the benefit of preventing, HIV within prisons by having people take the medication, so it reduces injection risk really quite dramatically. But it is actually something that will stabilize them during the course of their treatment as well. What are the implementation sort of questions that I think you want to think about? And Sheila hinted a little bit of this for tuberculosis, but when do you test for HIV? If you look across policies around the world, some of them say you do it upon entry. Some people say whenever you can do it. And other people say you do it as you release to the community, because they don't want the liability of having to treat somebody for HIV while they're in prison. Now, I would certainly make the argument that you take that opportunity from the time that they get in so that you can get them onto treatment, you can get them stabilized. How quickly can you evaluate and treat? So if you're in a jail setting, how quickly can you do that? In a prison, you have a little bit more time to actually do that. Then I would also say that because HIV travels with a bunch of buddies, substance use disorders, hepatitis C, tuberculosis, why are we not bundling this? This becomes an implementation opportunity to bundle massive screening for a lot of different things. If If you're going to draw the blood or do a finger stick, why can't you do it for a lot of things at once? You can't do tuberculosis because you got to focus on the lungs a little bit more than the blood. But can you bundle that all together by having a routine mechanism? There are some penitentiaries around the program that they call them intake centers. A person gets sentenced, and every single person spends 1 week at these places getting screened for a bunch of things, and it becomes an opportunity. In a jail, it may look a little bit different about doing that. And then, of course, these are implementation opportunities. So I talked about what are some of the problems in prison, staffing and resources and all these other sorts of things. What could we test compared to what we have today as an implementation strategy? Task shifting, all right? Our medical assistants, there's even a task shifting project that we did, I sort of aided it, but where we actually had some of the other prisoners go through with a little iPad and walk around and do quick screening for tuberculosis on an iPad and recording it. Now, I don't like the idea of having prisoners have to do that, but gosh, it was better than doing nothing. I mean, there are some ethical considerations, and we could spend some time talking about that. Telehealth, importing the clinician into the place. The alternative is that you have to wait and you have to put 30 or 40 people on a bus. You got to ship them out to the local area. The prison guards don't want them to go out. They'll limit it. They'll give them maybe once a week, and you sort of have a bottleneck. So how do you overcome that? By instead of shipping 30 prisoners out, you reduce the security risk and you provide it remotely. It's testable. We could look at the barriers to this. We could look at the facilitators. We could look at how it plays out on people who are incarcerated or on the prison guards themselves or the way that the healthcare system. That's testable. Teleeducation, by elevating the education of your nurses, your medical assistants, and your physicians so that they have some kind of egalitarian ability to provide comprehensive services in a place that's not designed to deliver them? Or are there other opportunities? And so I'm sort of open to them. I think that, you know, I've worked in probably 30 or 40 countries and prisons to date, and I keep learning about really new, clever ways, because whenever you are missing some of these key elements in these, so we think about low and middle income countries as being constrained resources, magnify that in prisons and think about, you know, kind of how much more constrained it is and what you can do, and you will create unique opportunities, and those unique opportunities might be ones that can be used in the community. Now, what we really have to talk about when we're talking about people who are experiencing incarceration is how do we intervene effectively when they get released? And so are we willing to accept the elevated risk, the elevated consequences of potentially overdose, of HIV transmission, if we don't get that part right? In general, if you take a look at almost every study, whether it's an intervention study or not, the ability to be able to communicate and to link with people after release is somewhere between 30 and 50%. And that's just the reality. What is that called? That's an implementation gap, right? These are things that we can begin to look at. So we should think about what's out there. So this transitional care is one of a cycle, and sometimes we have more than one opportunity to work with them. And so we have to be able to, as they leave, people leave prison, we have to, first of all, we have to link them to care. And we've done all of the big studies for people with HIV. I mean, literally 90% of the studies that have been published, linking them to care, we need to retain them into care, and we sort of ultimately need to have long-term outcomes. So, one of the things that I'm going to argue is that if you can effectively treat their substance use disorder so that when they leave prison, they are able to be more stable with regard to potentially finding employment, engaging with their families, not committing other crimes, and being able to go to their HIV medical appointment, the hypothesis is that that is going to be the pathway to get them to do well with their HIV care. Here are some data from our own state, and I will say that Connecticut is probably the crown jewel for healthcare for incarcerated people. It's probably the best data any place around. We had 29% of our people with HIV who were on antiretroviral therapy, representing people whose lives were chaotic and they were not engaged in care, our community had failed them, all right? They were not getting the services that they needed. Once they got released, this was in an earlier time when we weren't really giving everybody therapy, 71% of them were virally suppressed, and then 12 months after release, we went right back to the same level, about 30% who had viral suppression, which means that we lost that benefit. And that was because we had ineffective transitional care for these individuals. Now, part of what people who are deprived of liberty experience as they transition is a bunch of things that get in the way, all right? There's no way to actually fix all of those problems unless we sort of revamp our society. But I would say that, you know, these are a lot of the things that get in the way. But the substance use disorder is really creating the chaos. It really results in them not being able to be employed. Family who gets really annoyed and pissed off at their loved ones because they've relapsed again. I thought you got that fixed in prison. Prison is not drug treatment. How many people who have a substance use disorder, let's say an opioid use disorder, who are in prison, I don't care whether they're in there for 8 months or 8 years, what's the likelihood that they're going to relapse when they get released to the community? Give me a number. Speak up. 90%, 85 to 90%. Every single study on the planet, including from Malaysia, which showed 92%, they're going to relapse. So Mona got that right on the target. Incarceration is not addiction treatment. Here's a study. These are people who are released from basically compulsory drug detention centers. These were folks who either got weekly cognitive behavioral therapy counseling. CBT and counseling is not an evidence-based treatment for opioid use disorder. It is not, it is not, it is not. How many people were drug-free at the end of 12 months? 12%. So I said 92%, I meant 88%, but it's close. Compared to really 64% were abstinent from drugs in people who got methadone. All right, so this is really a several-fold difference with regard to treatment. Here's a modeling study that we did looking at 3 different contexts, 3 different major cities in Ukraine and in Kentucky and in Tehran. And we looked at the contribution in terms of reduction in death for people with various different sort of strategies that were scaled up. And these are medications for opioid use disorder. And if you added on medications for opioid use disorder, methadone or buprenorphine, including the incarceration setting, and that is that sort of last bar over there, you get a lot more bang for your buck because you have so many people who are at risk who go into incarceration. And remember, incarceration is really a major predictor for overdose and death. So once again, the added contribution of treating people with substance use disorders in prison and transitioning them to care will give you a lot of bang for your buck for reducing the evaluations. Here's a strategy that our team has developed, and it's an implementation strategy, and it doesn't have all of the complex layers. Screen, evaluate and engage, and treat. Set. All right, this is a new evolving strategy, and then I would say with prison it really needs to include transition with that. As part of that evaluation and treatment, you have opportunities to motivate and encourage patients to treat. Some of the earliest work on methadone and transitional care happened right here in Malaysia in a couple of papers looking at implementation opportunities and transition. This is a small pilot study, and it gets borne out in a larger study, but taking a look at what happens with regard to retention in HIV care after release from prison. I'm sorry, not in HIV care, in addiction treatment. And these are people who were released, and if they did not get methadone, they were 18% who were retained at 12 months versus 64%. And I'm sorry, all of them got methadone, sorry. It was whether you got a dose that was adequate or not. So if you got 80 milligrams or higher, your retention rate was 3.5 times greater. So dosing matters. It's not just that you get methadone, but you get the right dose so that your brain is saturated with the receptor so that there's not craving after release. Give people 25, 50 milligrams, they're not going to withdraw with 25 or 50 milligrams, they're just going to use when they get out. All right? Here is some recent data looking at linking to HIV care. This is not published, this is under review. And this is patients who either got methadone because they chose to get on it, or they got randomized to it. It was a study that was interrupted over time. It was done right here in Malaysia. And what it looked at was the linkage to HIV care. These were all people with HIV who had opioid use disorder, and it was part of a large trial with about 300 patients in it. And what you can see is that if they got methadone, they were significantly more likely to get linked to care after release from prison. One of the unusual things is you don't see much of a difference at 30 days, which was a surprise for me. But thereafter, the curves diverge and they get into HIV care. Now, what you really want to then do is you want to take a look and see whether they stay on HIV care. And the last part is whether you get viral suppression. But you're not going to have viral suppression levels unless you link them. So focus on each step and create these cascades, which become your implementation opportunities. So it may be the case that methadone is really good for linking, but then the next part of it is, do they stay in care? We don't know the answer to that. You might have to layer on some of these sort of smart designs that, that Jen was talking about. You may have to layer it on as you want to sort of move across the entire cascade. One of the things that I often think about as you're trying to introduce your evidence-based intervention is I want to know what are the patient-level factors with methadone. In other words, how fast do you escalate the medications? What are the side effects? What are the intervening effects of methadone on patients? You know, sometimes patients just don't want them. And so do you maybe perhaps part of your intervention is to educate? Or one of the things that we're doing globally is we're developing decision aids so that people can make choices for their own. So in other words, they need to know that they have a 90% chance of relapsing. Well, they say, why would I go on medication and go back on drugs and get dependent whenever I'm drug-free right now? And that's a real concern, but that's not the facts. All right, so let people make their own decisions based upon their own sort of levels, and decision aids are very helpful for doing that. Some of the staff level issues, the gatekeepers to the methadone clinic, or the HIV prevention, are the correctional officers who move them back and forth. If they don't want people to move, they're not going to move. They're not going to get their methadone. Your program will fall apart if the people who are on methadone can't get to it every single day. Are there stockouts in your prison? Oh, on the weekend, there's no one to give it to you. I can tell you, you can ruin the reputation of your methadone program by having these kinds of implementation factors that are driving that. And then, of course, is there support? When I first started working in Malaysia in the prisons, the Director General, who went on to do some really good things for HIV prevention, the first thing he said to me is that I can tell you that as long as I can breathe, not one single prisoner will ever get a dose of methadone. That was the first thing he said to me. Of course, we had a conversation and I noticed that his fingers were tainted kind of yellow. And I said, I don't have to talk about illegal drugs, I want to talk about nicotine and relapse prevention and all these other sorts of things. And I have to tell you that within a year, we had already piloted methadone. We took a trip to Iran. He thought the imams thought it was a good thing to do. And he went on to become head of the Malaysian AIDS Council with HIV prevention. He was head of the police, he was head of the prisons, when he said, I will never ever see a person, and he was the biggest advocate for methadone. So people can change. They just need to be able to see that there are some opportunities and a way to do some good. This is something that we just recently did last time I was here. Sheila and I and Hassan and a whole bunch of us went out to the prison. And basically, the prison program had dwindled down. There were about 20 patients on treatment. And we said, what gets in the way from going from 20 patients to, let's say, 200? The idea is, what are the barriers to scaling up methadone, beyond the measly, there's 6,000 or 7,000 patients in this prison, all right? So 20 patients on methadone is a drop in the bucket. And one of the things that they said that what gets in the way is that, the people who are deprived of liberty themselves don't really know about the benefits. That's probably true. And these were the officers, all right? And they had seen, most of them had seen methadone in the prison before. But they also said that there was really inadequate information by the custodial staff. And when we first introduced methadone, we did a lot of education and training. So all of that as sort of tachyphylax. And the system we had put in place was not resilient to the changes in the program over time. There were concerns about the quality. They talked about, oh, people really aren't on a good dose. They're still craving. They're not getting an adequate dose. So the quality of the program wasn't good enough. That's something that could be done. And they were very specific that the dosing was too low and these were the officers who were saying this, which was really impressive to me. And then there was still this other issue about people deprived of liberty not being motivated to take it while they were incarcerated because they felt like their drug addiction problem was gone. All things that could be amenable. So we said, all right, let's take these top things from the nominal group technique, and we would say, what would need to change in the prison? What could we do in the prison that would make a difference? Lo and behold, they got it right. Educational and motivational tools to help them make decisions, a decision aid, so that they could make sort of their own value-based decisions about whether methadone was the right treatment for them, all right? I think sort of, the idea of saying this is the right thing for everybody. I mean, as a public health person, I would say that's probably the case, but we sort of need to think about health and human rights. Decision aids are sort of designed to overcome some of those issues. Training programs for custodial staff and designing actually sort of programs that have quality indicators based upon getting people on a good dose. These were all things that were congruent, and they're things that are implementable. They are all things that we can do. All right, so this will be the next sort of steps that we're going to look at in terms of what we can do here. Just want to say that until we actually really decarcerate in a major sort of way, really rethinking the way that we're doing things, I think of our sort of prison systems as McPrisons. You've got the drive-through, and I sort of say, 12 million sentenced, 12 million sentence served, and the cycle goes on again. Let's take a few seconds and say, let's get some questions about what you might see as potential opportunities to be able to intervene with HIV or tuberculosis. I think Sheila and I can both sort of field questions in terms of what you think might be some other opportunities that we may not have really talked about. What I really was doing was I gave a framework and a couple of examples. But I still think that I have a ton of ideas about what to do, but I'd be interested in what other people think might be options. Ryan, you want to see if anybody wants to grab that microphone, or is everybody too afraid? This one's not afraid.
Hello, thank you so much, Dr. Friedrich, for the talk. Probably we can include a point-of-care test for TB testing among prisoners, because currently I think some hospitals and some clinics in Malaysia are using TB lab antigen urine point-of-care test. Of course, it may not be the most sensitive or specific TB testing, especially for pulmonary TB, but at least it is something. So, what do you think about that? Thank you.
I have an opinion. I know Sheila does.
The urine lab is a fantastic test for a very specific demographic. That's for people who have